Fever, defined as a body temperature of at least 100.4 degrees Fahrenheit or 38 degrees Celsius, is a common symptom that can indicate the presence of infection. When talking about patients returning from recent travel, a fever might point to an illness endemic to the area they visited or emigrated from. There are many conditions to think about here, but assessing for the presence and type of rash can help you narrow down the differential. When a patient presents with a fever after traveling, first perform an ABCDE assessment to determine if they are stable or unstable. If unstable, stabilize their airway, breathing, and circulation. Next, obtain IV access, give IV fluids, and start continuous vital sign monitoring, including blood pressure, heart rate, and pulse oximetry. If needed, provide supplemental oxygen and consider starting antibiotics. When it comes to stable patients, your next step is to obtain a focused history and physical examination. History typically reveals recent travel and fever, with or without general malaise or headache. On exam, there is elevated temperature, but you might also find tachycardia and a rash. Assessing for the presence of rash is very important, as it'll help you narrow down potential diagnoses. If a rash is present, assess the rash morphology. Let's start with macular rashes, which appear as flat discolorations on the skin. First up is African sleeping sickness, also known as African trypanosomiasis. This illness is caused by the protozoan parasite Trypanosoma brucei and transmitted via tsetse fly. Patients report a history of recent travel from sub-Saharan Africa and getting bitten by tsetse flies. Soon after, they develop headaches and, in some cases, mood changes, drowsiness, and even weight loss. As for the physical exam, it shows a painful chancre at the site of the fly bite and trypanid rash, which is a transient rash on the trunk that appears as a predominantly macular rash with wheals. You might also note altered mental status. With these findings, consider African sleeping sickness and order microscopic analysis of the blood, cerebrospinal fluid, or chancre fluid. If the results show visible Trypanosoma brucei parasites, diagnose African sleeping sickness. Moving on to dengue fever from the genus Flavivirus, which is transmitted by Aedes mosquitoes. These patients have a history of recent travel from tropical or subtropical regions, mosquito bites, headaches, a significant amount of muscle and joint pain, and nausea. They might also report vomiting with abdominal pain. Physical exam typically reveals a diffuse macular rash limited to the limbs and face. You might also note petechiae or purpura as the infection progresses. With these findings, consider dengue fever and order nucleic acid amplification testing, also known as NAAT, of serum or serum antibody testing. If the results are positive for dengue viral RNA or anti-dengue immunoglobulin M, diagnose dengue fever. Here's a clinical pearl. Patients with dengue fever should avoid aspirin or other NSAIDs due to an increased risk of bleeding. Okay, let's move on to infections with maculopapular rash. This rash appears as a mix of flat discolorations and raised bumps. First up is Zika virus, which is also from the Flavivirus genus. Patients report recent travel from tropical and subtropical regions with a history of mosquito bites. They may have joint pain, headache, vomiting, or itching. Exam typically shows a maculopapular rash and possibly non-purulent conjunctivitis. If this is the case, consider Zika infection and order NAAT of the cerebrospinal fluid, serum, or urine. Alternatively, you can order serum antibody testing. If the NAAT is positive for Zika viral RNA or anti-Zika immunoglobulin M is positive, you are dealing with Zika virus infection. Time for a clinical pearl. Zika virus has been linked to microcephaly and other birth defects, so pregnant patients should be cautioned against traveling to areas endemic for Zika virus. Next up is chikungunya infection, an alpha virus from the Togaviridae family transmitted via an Aedes mosquito bite. Patients with this infection report travel from Africa or Southeast Asia, mosquito bites, headaches, nausea, and possible severe joint pain. Exam typically reveals a maculopapular rash on the trunk and extremities that may extend to the face, palms, and soles. With these findings, consider chikungunya infection and order virus-specific NAAT of serum or antibody testing. If the NAAT is positive for chikungunya RNA or anti-chikungunya immunoglobulin M is positive, diagnose chikungunya virus. Now let's discuss typhoid fever caused by strains of Salmonella enterica. In this case, patients report recent travel from developing countries, especially in South Asia, where they consumed unclean food or water that was likely contaminated with feces. They might also report gradually rising fever, malaise, headache, abdominal pain, vomiting, and diarrhea. Physical exam reveals bradycardia, hepatosplenomegaly, and transient rose-colored spots on the trunk or abdomen. With these findings, consider typhoid fever, also known as enteric fever. Your next step is to obtain blood and stool cultures. If either grows Salmonella typhi or paratyphi, diagnose typhoid fever. Okay, let's switch gears to petechial or purpuric rashes. Petechiae appears as tiny reddish dots, whereas purpura appears as large purple discolorations. First up is Ebola. This is a virus in the Filoviridae family that causes viral hemorrhagic fever. Patients with Ebola typically report recent travel from sub-Saharan Africa or Southeast Asia, as well as contact with the body fluids of an infected person or animal. They also have headaches and myalgia and may have bloody diarrhea and vomiting. Physical exam might show a petechial rash and mucosal bleeding. With these findings, consider Ebola and order viral-specific NAAT of the serum or viral isolation tests. If the NAAT is positive for Ebola RNA or the virus itself is isolated, diagnose Ebola. Keep in mind that you should report all suspected Ebola cases to the health department to prevent mass outbreaks. Finally, let's discuss Rocky Mountain spotted fever caused by the bacteria Rickettsiales. These patients report recent travel from the southeastern or south-central United States and may have a known tick exposure. They typically have symptoms like fever, myalgia, headache, and malaise. History reveals a rash that developed 2 to 4 days after their fever began. When it comes to the physical exam, the patient will be ill-appearing with a generalized rash that's macropapular at first and later becomes petechial. The rash begins on the extremities, spreads to the trunk, and involves the palms and soles. With these findings, consider Rocky Mountain spotted fever. Initially, the diagnosis is made clinically. If needed, you can order serology for Rickettsia rickettsii, which, if positive, confirms the diagnosis of Rocky Mountain spotted fever. Here's a clinical pearl. Another common infection transmitted via ticks is Lyme disease, caused by the spirochete Borrelia burgdorferi. Your patient might report recent travel from the northeastern or north-central United States. Look for the classic bullseye rash called erythema migrans that appears as an erythematous macule with partial central clearing. Like Rocky Mountain spotted fever, this is a clinical diagnosis, and testing is not needed if your patient presents with early manifestations of Lyme disease. The diagnosis can be confirmed with serology testing. Okay, now that we've covered febrile travelers with a rash, let's discuss cases when a rash is not present, starting with Japanese encephalitis. This illness is caused by a virus from the Flavivirus genus and transmitted by Culex mosquitoes. Patients report recent travel from Asia, mosquito bites, headaches, and possibly vomiting. Exam might reveal mental status changes, weakness, and neurological deficits. With these findings, consider Japanese encephalitis and order virus-specific antibody testing on the patient's cerebrospinal fluid or serum. If immunoglobulin M is present in serum or cerebrospinal fluid, diagnose Japanese encephalitis. Next up is malaria, a protozoan parasite of the genus Plasmodium that's transmitted by infected Anopheles mosquitoes. These patients report recent travel from Africa, Asia, South or Central America, and the Caribbean, as well as mosquito bites, headaches, myalgia, and general malaise. Physical exam might show mental status changes and weakness. With these findings, consider malaria and order parasite-specific NAAT of the serum or microscopic analysis of the blood. If the NAAT is positive for malarial DNA or the microscopic analysis shows visible Plasmodium parasites, diagnose malaria. Let's move on to yellow fever, an infection caused by a virus from the genus Flavivirus, which is transmitted by the Aedes or Haemogogus mosquitoes. Your patient will report recent travel from sub-Saharan Africa or tropical South Africa, along with a history of mosquito bites. They may have a backache, headache, or episodes of vomiting, while physical exam might show jaundice. With these findings, consider yellow fever and order virus-specific NAAT of the serum or virus isolation testing. If the results show a positive NAAT for yellow fever RNA or the virus is isolated, diagnose yellow fever. Here's a clinical pearl. Most individuals with yellow fever have minimal symptoms and no skin rash. However, if severe enough, yellow fever can present with petechiae or ecchymoses. Finally, let's discuss traveler's diarrhea, which is most commonly caused by Escherichia coli or Salmonella bacteria, rotaviruses, and Giardia parasites. These patients have a history of recent travel from locations with poor plumbing or limited refrigeration, as well as contact with contaminated food or water. They will report diarrhea that might be bloody, along with possible nausea and vomiting. Exam may reveal abdominal tenderness and increased bowel sounds. With these findings, diagnose traveler's diarrhea. Alright, as a quick recap, fever in a returned traveler can indicate an infection endemic to the region they visited. Start by obtaining a history and physical exam, and then assess for a rash. Macular rashes are associated with African sleeping sickness and dengue fever, whereas maculopapular rashes suggest Zika virus, chikungunya virus, and typhoid fever. Petechial or purpuric rashes might be found with Ebola and Rocky Mountain spotted fever. On the other hand, if you don't find a rash, consider Japanese encephalitis, malaria, yellow fever, or traveler's diarrhea.